Hi everybody, this is Dr. Woeller. I appreciate you joining me again tonight for another Great Plains installment of these monthly webinars. Tonight we're going to be talking about just some select cases, from my practice. And one of the things about, case presentations is, over the years there are so many kids, from so many, different areas throughout the United States and really around the world, with so many different presentations and issues. It's impossible to, do one presentation on all the different various, issues going on with kids on the spectrum. So what I did is I handpicked a few that highlight some very important areas I think everybody needs to know about. Many of these have been talked about in my book. And then I'll certainly throw in some clinical pearls, throughout the presentation as well to kind of get you thinking about perhaps maybe your own child. And so I think you'll find it interesting. So with that, let's go ahead and get started. Just to a few housekeeping items here. To make everybody aware, we just launched a new website. It's called labtestsplus.com. And let me get rid of that real quick. And what this website is this actually allows for individuals throughout the United States and around the world to have access to integrative medicine testing, not only from Great Plains, but a few other labs as well. Now we're focusing primarily on stool, urine, saliva, and hair testing, and a few finger prick testing for vitamin D and food sensitivities. And with these labs, actually, when we receive the results and when you get the results, you'll also have a personal written interpretation either from me or my partner, Dr. Tracy Trencatella, who's a naturopathic doctor, and she specializes a lot in adrenal hormones and hormone imbalances. So, and then also with each lab test, if it's indicated on the lab test, various protocols, medication recommendations, supplement recommendations, and dosing, etc., will come with that as well. So I'd encourage you to check out labtestsplus.com if you're interested in not only doing testing on your child, but even perhaps yourself. And then, of course, I'm always available for ongoing questions through my subscription website at autismactionplan.com. I work with people through this website on a daily basis, answering questions related to biomedical intervention. And whether you're working with a doctor or kind of doing this on your own, I'm there just to kind of as a backup, second opinion, help troubleshoot some ideas, whatever it may be. So autismactionplan.com. And then if you want to just get more general information on me, my practice, links to various books that I have, you can do that at drwoeller.com. Okay, so tonight I'm going to go through a typical scenario of a child diagnosed with autism. Now, with that, I want people to understand that, it's an example. However, within that example are some actual real-life things that I've seen over the years. And so the example actually tends to mimic the vast majority of kids that I see in one way or another. And then case one, we're going to talk about yeast and pervasive developmental disorder. And then case two, we'll talk about things that tend to contribute to an aggressive behavior. And then some different scenarios related to constipation and aggressive behavior, which I think you'll find interesting. A case of self-injurious behavior that was really kind of a complex case as it evolved over time. I'll show you some interesting slides on test samples of oxalates and Clostridia markers as they've reduced over time. And then we'll end with a case presentation just real briefly on methyl B12. So let's go ahead and talk about, as an example, a typical child diagnosed with autism and what I'm describing here as regressive autism. And again, this pattern is only an example, but it tends to highlight some important areas. So in this particular circumstance, the child, and that child could be a boy or girl, okay? But we know that the ratios tend to be more weighted towards boys. So you may hear me say he as part of this, but it applies to all kids. So the child is born seemingly healthy, either born via C-section or vaginal delivery, and Pitocin is often used to assist in labor. The link with Pitocin I want people to understand is in relationship to its potential inhibition of natural production of oxytocin. And there's a therapy called Respin-A, which I've used in my practice now for many years, which helps to improve socialization and language development, fine and gross motor skills, that has an indirect influence on serotonin and oxytocin function. And we also know that oxytocin as a therapy has been helpful for some individuals on the spectrum as well with respects to socialization, bonding, facial expression recognition, decreased anxiety, etc. Okay, so in this particular situation, there's no apparent issues at birth. The child may or may not have received a hepatitis B vaccine. At 2 months, the child receives their first series of vaccines, and then commonly within the first 3 to 4 months, the child is diagnosed with an ear infection, and they tend to get their first round of antibiotics. Now, the child may be successfully breastfeeding, for the first 3 to 4 months, and then oftentimes is switched to formula. A second ear infection is diagnosed at around 4 to 5 months, and again, another round of antibiotics is coming on board. Then solids are introduced around 6 months. More antibiotics are given, unfortunately, for an unresolved ear infection, and then the child gets their 4 to 6 month vaccines, and they continue to develop normally. They're playful, they appear happy and content, and eye contact appears intact. Now, they may possibly get another course of antibiotics prior to the first birthday because of these repeat ear infections. At 1 year, the child is usually switched either from breast milk or formula to cow dairy. They continue to progress, developmentally pretty well, and they're starting to verbalize some words, typically things like dada or mama. Ear infections still tend to be an issue, and the child is still given more antibiotics to try to treat that problem. Now, the child at this point may develop some periodic loose stools after the cow dairy has been implemented. Between the 12th and 15th month of age, the child will usually receive another round of vaccines, including the MMR and the chickenpox vaccine. The parents begin to notice a marked change in stool patterns, including an increase in diarrhea, light-colored stool, and this sandy-like substance sometimes starts to emerge. Now, that sandy-like substance actually can be a couple things. It can be oxalates. It can also be the fact that bile acids are being inhibited from production because the liver is now being taxed, and the liver is not producing enough bile acids because there's a relative decrease over time in certain sulfur-containing amino acids, one of them called taurine, which is important for the production of bile acid. Around 15 to 18 months, the child begins to lose words. They're no longer saying dada or mama. Now, they may appear deaf as they no longer respond to the name, and typically parents at this point will go and get a hearing test, and that all checks out to be okay. The child starts to fixate on spinning objects, things like fans, the wheels on toy cars or trucks, and that this pattern usually takes about 2 to 3 months to develop, but in some cases, and I've seen in my practice, it can happen much more rapidly, sometimes within hours, more commonly within a few weeks. Now, by the time the child is 18 to 20 months old, they're no longer communicative, they appear isolated and withdrawn, and their bowel problems continue, such as the diarrhea. More ear infections keep emerging, despite the fact that they're just being placed on more and more antibiotics. The parents are told that most kids will go through some type of transition period in their toddler years, and that boys will oftentimes have delays in language. And I've seen that scenario many, many times. This cycle continues until it's evident that the child is not developing normally, but instead is losing ground, from speech standpoint, socialization standpoint, with other children their age. The child is eventually seen by a specialist, given a diagnosis of autism, and the provided various services, whether that's education services, speech services, behavioral therapy, or whatnot. Unfortunately, there's no significant medical therapies are either investigated or implemented, except, in many cases, a neurologist or some other specialists might run a Fragile X test, maybe a basic blood chemistry, but not much beyond that. In many cases, those examinations never happen. Parents' concerns, and this is very typical, regarding their child's health, their diarrhea, the repeat ear infections, possibly some kind of problem linking back to vaccines, are, for the most part, or totally and completely disregarded. Okay, so that's a typical scenario that I have seen repeat itself over the past many years. So let's talk about case one, which is a case of yeast and pervasive developmental disorder. Now, when I first saw this child, they were 2.5 years of age at the time of their first visit, and their development was, fairly typical. The vaginal delivery, there was no birth trauma. The mom reported no issues with pregnancy. At first 12 months, they had typical development. They were pointing. Eye contact was good. Physical milestones seemed to be developing. And in this particular case, they were laughing at the dog. So there was some humor and awareness of what was going on around them. At about 13 months, parents noticed that there was a lack of pointing, and interestingly enough, the child started becoming fixated on fans. They still had good eye contact. They seemed connected emotionally with parents, and there was some language, mama and dada, like I'd given in the previous situation, and a few other descriptive words for the family dogs and a few toys. At about 16 months, no more language had been gained. And at this point, they noticed that the child was becoming more disconnected from the environment or environmental awareness, and also no longer interacting with the family dog. Was still engaged with the parents, but eye contact seemed to have disappeared at times, or at least was fleeting at best. At 18 months, no longer talking, only nondescript babbling, no interactive play, and was really fixated on toys. Child eventually was given a diagnosis, or a preliminary diagnosis, of PDD-NOS, and the parents started their own search from there. Now, medical history: child was breastfed until about 9 months, began baby food at 6 months, and received their first antibiotic at 7 months for their first ear infection. And then the repeat ear infections started coming about. 10 months, 11 months, 14 months, all treated with antibiotics. They received their first vaccines beginning at 2 months. At 6 months, the parents reported back to their pediatrician's office that the child had a high fever, and they were concerned about it. They were told to give them Tylenol, which they did, and then from every subsequent vaccine they're out, they were just pre-dosed with Tylenol, which is still a common recommendation in most pediatric offices. There was no immediate regression that was recognized as being linked to vaccination. Now, the child's stools, after starting to eat baby foods, were solid, for about the first 2 to 3 months. Remember, that was occurring around age 6 months. But around 9 to 10 months, the stools started to become loose and smelly, and at this point, mom had stopped breastfeeding. 12 months, parents introduced cow dairy and wheat. Stools became slightly more loose and smelly, but there was no change in behavior. So, biomedical intervention. Like a lot of parents, they start to initiate things on their own, which is totally fine. At 26 months, the mom had started reading about different things to help with kids on the spectrum, came across information about the gluten casein-free diet, and she initiated on her own. Stools very shortly thereafter were no longer loose. Child also started to acknowledge the family dog for the first time in over a year. At 2.5, the parents introduced a multivitamin and multimineral with some high-dose B6, and that further seemed to increase some focusing and attention for their child. At this point, I kind of come on the scene here, and I ordered an organic acid test from Great Plains. By the way, this was one of the first kids that I had seen in my practice way back in the late 90s. And so at that point, the only thing I really knew what to do was to order an organic acid test. The levels came back extremely high, over 800, and the Clostridia markers were normal. So I remember at that time, I didn't really know much what to do, and I actually had a consultation with Dr. Shaw from Great Plains Lab and went over the test with him, and the general recommendation was to start some nystatin. So I was conservative, and that's where I started. I started them off at 125,000 units 3 times daily, and within about 2 weeks, there was the child no longer was fixated on spinning objects. He had improved eye contact, his abdomen was less bloated, and his stools were remaining to be firm in addition to the nystatin and the diet that the parents had initiated on their own. We then also introduced some probiotics and some digestive enzymes with meals. We repeated an organic acid about 6 months later, and the arabinose had come down to about 350. And so, it had come down, and the child was obviously improving. I figured at that time, we'll just go ahead and give more. Okay, so we increased the nystatin to 500,000 units, which honestly at this point is a general starting dose of where I start with most kids, is at 500, as opposed to the 125, way back, many, many years ago. We started introducing some grapefruit seed extract, and after about 14 months of the parents, doing the nystatin, the probiotics, the supplements, being very regimented with the diet, his yeast markers eventually normalized. And the outcome was that his PDD diagnosis was eventually dropped. He developed age-appropriate language and social progress. He continued the diet, for another 6 months or so. They continued the multivitamin, multimineral indefinitely. We eventually discontinued the nystatin and grapefruit seed extract, and this particular child did extremely well. And again, that was one of the first cases that I had seen many years ago, and it was a great success. Let me introduce you to, if you've not seen any information from Dr. Shaw about Clostridia bacteria, and you'll see why I'm introducing this information here. This is part of these slides. There's only about 7 or 8 slides. It's from a much larger lecture from Dr. Shaw from Great Plains about the mental health effects of Clostridia bacteria and the metabolism that it goes through and what it does biochemically and how that can affect people adversely. So we know that Clostridia, and there's a wide variety of different types of Clostridia bacteria. They're spore-forming bacteria, which are difficult to eradicate when they exist in the spore form. They're anaerobic, which means they don't like oxygen. And they're very difficult to kill, and that's one of the problems with them. The one type of Clostridia that gets most press is the Clostridia difficile, which is becoming a real problem in a lot of hospitals these days because it's very resistant to treatment, and it causes a very severe form of inflammatory bowel disease called pseudomembranous colitis. So these are the types of Clostridia, that are known to produce different types of biotoxins. C. difficile, C. botulinum, which is food poisoning, and a variety of others. And this actually comes from this Nutritional Neuroscience in 2010. Now, the chemical that they're analyzing here is HPHPA. And we know that Clostridia not only has relevance in autism, but in a wide variety of other mental health disorders and physical disorders as well. Crohn's disease, seizure disorders, obsessive-compulsive disorders, etc. One of the things that's happening with Clostridia and the HPHPA chemical is it's negatively influencing the dopamine areas in the brain. And this is just a cross-section of a brain here with arrows pointing to the areas that are heavily concentrated in dopamine. Well, biochemically, it makes sense when you start to break it down step by step. When you do an organic acid test, you're going to be looking at a couple different markers on that test. One is you're going to be looking at something called HPHPA, which stands for 3-hydroxyphenyl, 3-hydroxypropanoic acid. There's another chemical, which we're not really getting into here so much, called 4-creosol. 4-creosol is produced by Clostridium difficile, and these are both analyzed through the organic acid test. What happens is when we eat and ingest phenylalanine in the presence of these bacteria, it is either converted into tyrosine in this pathway to become dopa, which becomes dopamine, which is necessary. And the byproduct of dopamine metabolism is a chemical called HPA, or homovinylic acid. Now, HPHPA and 4-creosol inhibit a specific dopamine-converting enzyme called dopamine beta-hydroxylase. And dopamine beta-hydroxylase converts dopamine to norepinephrine. Now, norepinephrine is very important for learning, for memory, for attention, cognitive awareness. And when there's deficits of norepinephrine, there's definitely problems with attention focusing, etc. So when we inhibit this conversion, we start to get an increase of dopamine. And often what you'll see on the organic acid test, when you see HPHPA high, you'll often see HVA high and sometimes VMA low or low normal, because we're not getting this crossover conversion. This is just one urine sample taken from an individual with severe autism. And as you can see, the solid burgundy, or we'll call it a burgundy line here, is the HVA, which is the breakdown of the dopamine, which means there's an excess production of dopamine occurring, which is then causing an excess production of HVA. The orange dotted line is the HPHPA marker itself coming from Clostridia. The VMA, which is linked to norepinephrine, is really not increasing at all. So as the HPHPA goes up, we get a corresponding increase of the HVA as well. And as the HPHPA goes down, we get a corresponding decrease of the HVA as well. And this is what it looks like when you do that test. Oftentimes you'll see the HPHPA marker very high and the HVA level sometimes elevated. Sometimes you'll see the VMA elevated too. That can come about because of stress and anxiety and other factors. Now, why this is important is that our body, our brain, our nervous system, and every organ function in our body is balanced by the part of our nervous system called the autonomic nervous system. We have the parasympathetic and the sympathetic. And all of these things have a tremendous influence on blood flow, on respiration, on the production of saliva, the production of digestive juices in the gut. There's nothing it doesn't touch. And what happens when we get an increased production of dopamine over time is that dopamine starts to infiltrate itself into the different receptor sites that are affecting these different organs. And that creates a major imbalance in the autonomic nervous system. It can create imbalances in cardiovascular function, digestive function, sleep, immune function, etc. And so everything needs to be in balance, obviously. And when we have too much dopamine being produced, it can lead to a lot of problems. What we often see is we see individuals on the spectrum anyway who are neurologically sensitive to too much dopamine become very irritable, agitated, sometimes aggressive, and sometimes self-injurious. And in extreme cases, Clostridia bacteria has been linked to other mental health disorders, even schizophrenia. So that brings us to case 2, and this is called a contributor to aggressive behavior. So the first time I saw this particular child, they were 5 years old, at their first visit. A C-section, planned C-section. There was no pregnancy complications. They had a little bit of colic as an infant. Overall, typical development, upwards of 10 months. The parents did report, during that first meeting as they looked back, that he seemed to lack a lot of need for physical contact, but it wasn't anything that really struck them as too concerning. His eye contact was okay, upwards of about 10 to 11 months. physical milestones appeared fine. He was babbling, but there never was any word development that ever came about. Language development noticed to be significantly delayed by 15 months, but they didn't really appreciate any other types of deficits. Was playful and happy overall, and was engaging with his sibling. Now, medical history was breastfed for 1 year, and like a lot of kids, put on cow dairy solids at 6 months. He also had multiple ear infections with corresponding antibiotics, and as the parents reported, it always seemed like he was on antibiotics for ear problems. His digestion tended to be more constipated, if anything, during the first and second year, and often the parents reported that they'd have to use periodic suppositories to get him to poop. Vaccines began at 2 months up through 2 years, and then they just stopped on their own. Now, they did report fevers after each shots, and the parents also remembered at 8 months, after the series of vaccines around that time, he just seemed excessively irritable. But they didn't notice any immediate regression pattern, so nothing was really, stated up front to any physician at that time. At 15 months, he got the MMR, chickenpox, and a flu shot. And subsequently thereafter, at loose stools for 3 days, had a fever, was told by the pediatrician to give Tylenol. He was irritable and sleepy, but then he tended to seem to recover okay. So again, nothing that was, the parents were real concerned about. However, within about a month, he started acting really silly and waking up at night, hyper and laughing a lot. Now, medical history, by 20 months, he just seemed to disappear, just seemed to regress into his own world. There was no expressive language, poor social interaction, no interest in sibling or other neighbor kids, became easily agitated, but he would still have this silly and laughing behavior. Started doing some side glancing, where he's looking out of the side of his eye or standing real close to the TV screen. Hand flapping, finger twisting became more obvious, and eventually around the age of 3 got an official diagnosis of autism. They were referred to a pediatrician, or the pediatrician, referred him to a neurologist. Neurologist ran a Fragile X test. It was normal. Stated there was nothing else to do, nothing else he could do. Parents requested an MRI, told, doesn't need it, and they were sent on their way. So they started doing some on their own research, like many parents, came across the information on the casein-free diet, initiated the casein-free diet first, and almost immediately started noticing improvements in eye contact, sleeping better through the night. Didn't really get much of an added benefit by the gluten-free diet. They started a multi-mineral vitamin, tended to make him hyper and a little agitated, so they stopped that after about 3 weeks. At the age of 4, he developed an upper respiratory infection and was given an antibiotic treatment. Within the week of completing that treatment, he became unusually agitated and aggressive, hitting, screaming, biting, scratching. It was just wasn't consolable. And this tended to go back and forth for about 2 weeks. It got better, but never really went away. So he never really fully went back to baseline prior to that upper respiratory infection at the age of 4. Parents also, implemented on their own some grapefruit seed extract, caprylic acid. They did see some improvement in eye contact. His focusing was improved a little bit. The aggression decreased some, but not significant. So then we ran, some testing, and we decided to do a urinary peptide to just make sure that his diet was clean. And sure enough, he had high levels of gliadin and casein peptides, even though the parents were really pretty confident that he was 100% GFCF, so they needed to do some dietary adjustment. And we did an organic acid test. His rhabinose was high, which certainly indicates a yeast problem that can contribute to a lot of that silly, goofy behavior. But then his HPHP levels were extremely high, which is going to be more telltale of that aggressive, irritable, agitated, moody type of behavior. So we initiated a treatment of Flagyl, which is an antibiotic useful against Clostridia. Also did some nystatin along with that to treat the yeast, and I implemented some Clostridia, which is a specific probiotic to give us further maintenance against that Clostridia long term. Now, 5 days into the flagell treatment, his aggression and irritability disappeared almost completely. Within 3 weeks, he was happy, content, and playful. We continued with the nystatin diet, started to implement a low-sugar diet, and he just continued to progress overall. Social interaction was better, sleep was behavior better, behavior was better. Eventually, we did initiate methyl B12 therapy, and that further moved him along with his attention and expressive language. Unfortunately, like some cases, they were lost to follow-up, so I was never able to get absolute confirmation of the eradication of Clostridia, but basically, the way he responded so positively to the antibiotic therapy and the other therapy, it's pretty good bet that it had reduced significantly, if not had gone away. So a couple situations here on aggressive behavior and kind of some odd behavior with respects to constipation. And this is just a patient we'll call patient A. A 5-year-old boy, age of diagnosis at the age of 2.5. Now, like a lot of kids, expressive language, social withdrawal, sound sensitivity were his main issues. The good thing is he was non-aggressive or self-injurious. Now, the main reason, and one of the most concerning things for the parent amongst the list above, was that he had this weird repetitive behavior where he would lay flat on the floor and rub his belly back and forth. And this would go on for, hours if he could. On physical examination, his abdomen was quite distended, and he had this pregnant belly look to him. Now, the parents reported that he had normal bowel movements every day. He would actually poop every day, but he did have a lot of foul-smelling gas. And so on examination with respects to an X-ray, it revealed that he had significant constipation. Once his constipation was resolved with some laxatives, magnesium citrate, and some fiber, he no longer did the belly rub, and that tends to be his MO. If he starts getting constipated, he'll start belly rubbing again on the floor. And this was a good lesson from the standpoint that even though your child may be having a bowel movement every day, doesn't mean that they can't have constipation, because some of these kids have tremendous amount of stool in their gut, and they may be just pooping out a section of a longer piece of poop. And particularly if they have ongoing, abdominal bloating and their belly feels real hard, constipation is quite likely. Now, there was another case, kind of interesting with respect to an older boy on the spectrum. He had language, he could have a conversation. Socially, he was a bit awkward. Behaviorally, very, very stressed. A lot of anxiety, tended to chew on his shirt, particularly anxious about school, and a lot of anxiety, focused around the bathroom. One of the concerning behaviors is that, he would become obsessive and combative emotionally when he would complain of his stomach hurting. And he'd often report that his stomach hurt a lot after eating and many times throughout the days. The parents noticed that he would actually bend forward on the toilet when he tried to have a bowel movement, and he could spend quite a lot of time in the bathroom doing this. So he's just sort of bending forward to try to compensate for some problem, whether it's severe constipation or pain, whatever was happening. His pediatrician suspected Helicobacter pylori, which is a bacterial infection in the stomach. That came back negative. He was given some reflux medication, which wasn't helpful. And then over time, things like magnesium oxide, which slightly helped, or suppositories when he was younger gave some relief, but there was never any consistent improvement in his constipation. And then eventually he was referred to a gastroenterologist who was able to do a physical examination and diagnosed with rectal prolapse. And this was basically a condition where the rectum becomes so stretched and strained that it no longer can hold this normal tone, And so, what happens is you can get protrusion of the rectum coming out from the anus area, and it makes it very difficult to have a bowel movement. And that's likely why he was doing the bending forward. It's a pressure effect or a compensatory effect to try to get some physical leverage in order to try to get the stool out. And then, the GI doctor, prescribed some magnesium citrate with Miralax, increased fiber, high-dose probiotics, and working with them to try to create a routine on going to the bathroom on a more regular basis. And then finally, patient C in this particular scenario was a boy I saw many, many years ago. Was 2.5 at the, he was 2.5 he was given a diagnosis at the age of 2.5. He was older when I saw him, around 13, 14 years of age. And like a lot of kids who were severe, nonverbal, poor socialization, a lot of anxiety, a lot of sensory-seeking behavior, and some aggressive behavior. The main reason for the consult was the mother was just beside herself with his aggressive behavior and destructive tantrums. Also, his main physical challenge was constipation. He literally would not have a bowel movement for 5 to 6 days. The mom had done Ducolax suppositories. The pediatrician had tried Miralax, and nothing was really helping to any significant degree. On physical examination, and again, he was pretty strong kid, could be pretty aggressive, so being able to do a thorough examination on a child like that's tough. But I did note, that he had, pretty significant abdominal distension. So I decided to implement something that I'd learned many years ago, and this program it's an example, but it tends to work pretty well for most kids. To try to just get the poop out. I figured he was quite constipated, and if we could somehow get poop out of him, he'd probably feel better. This was before doing even any testing. So we initiated a Fleet's enema. We did that 2 hours prior, and then we started some Miralax. We did a half cup and 6 ounces of water every half hour for 6 dosages, and then followed that with a Ducolax suppository 1 hour later. And then this went on for a couple days, eventually transitioning to Miralax, twice daily for 3 weeks, and then getting off of things like Miralax and trying to accomplish the same thing with some ground flax seeds, some slippery elm herb, magnesium citrate, for more long-term basis, trying to do things a little more naturally and not be on the Miralax long-term. And it worked significantly. It worked like a charm. Matter of fact, this was one of many large stool boluses that came out of this kid. He had massive stool dump from doing this program. That, by the way, is a police flashlight that is laying alongside that one particular bowel movement. And you'll notice how hard it is because it's been in the bowel for so long, it starts to become dry and dried out and dehydrated. Now with that, the mother reported that within 4 days of a bowel evacuation, his aggressive tantrums diminished 75%. Mom also reported great progress overall. He just seemed happier. He was more calm, less agitated, sleeping better. But he was still remained aggressive at times. Nothing like he was before, but it still could be a problem that would rear its ugly head. But it was interesting because it wasn't sort of all the time. It really only happened when he was being reprimanded for some type of negative behavior. So I inquired further about his aggressive behavior patterns. And what I realized is not everything in the world of biomedical intervention for autism is biomedical. It's not all a physical problem. So I asked the mom, I said, who does he tend to hit? And it turns out that he tended to hit his mom, his sister, his aunt, and in the past, his grandma. Now, he wouldn't hit his brother, his father, or grandfather. So I inquired further, and I said, well, why doesn't he hit grandma anymore? Well, it turned out that grandma, after getting hit and not doing anything for such a long period of time, finally got frustrated of being hit. And one day she slapped him back in the face and stated, "Don't ever hit me again." And from that point forward, this particular boy never hit his grandma again. And what I realized and what I described to the mom was that this is not a biomedical issue per se. There's no medication or supplement or diet that's going to change this behavior. This is a behavioral problem. It's a learned problem that he has been allowed, to do, and he's learned that he can hit women, which is completely inappropriate, because he intuitively knew, I'm assuming, that he wouldn't hit his dad or hit his brother because he'd probably get hit back. So this is where they needed to work with a counselor or a therapist who could try to break this problem. Okay. So let's talk about case 3. And this was a case of very serious self-injurious behavior and quite complex. This particular child was 8 at the time that I saw them. And parents reported great development. Everything seemed fine up till about 18 months of age. Physical, social, language all appeared normal. He was talking, understanding commands, attentive, sleeping well, and his mom, quote, end quote, he was a normal boy. Now, medical history, there was no obvious digestive problems. He had one ear infection at the age between 8 to 9 months, and they got an antibiotic for that. A little bit of trouble with eczema, tended to run in the family, but, not a huge problem. And then at 18 months, the child received their MMR combination vaccine. Parents reported very sudden changes. Diarrhea for the first 2 weeks, some of them bloody, a major flare in his eczema that persisted for months, complete loss of language in 2 weeks, eye contact was gone, as well as any social interest. And he became very fixated on just certain foods, dairy and gluten foods, and became a very picky eater. And his mom described to me during that first meeting is my child disappeared before my eyes. Now, he also started becoming very aggressive, irritable, started sleeping poorly, and would literally be up for hours every night. And this pattern just continued for years. One point he was given risperidol, common medication for autism, didn't really help. He actually developed something called, or they thought developed tardive dyskinesia, which is an involuntary type of muscle movement. It can be very serious. Luckily for him, they discontinued the medication, and he didn't have any permanent deficits from that. He was placed on naltrexone. You probably heard of low-dose naltrexone, which is a compounded medication given, usually about 4.5 milligrams for individuals with autoimmune disorders. It could be quite helpful. But naltrexone in higher doses can actually be helpful for aggressive and self-injurious behavior, and it has been used in the autism world for that. It did seem to help lessen his aggression a bit, but not significantly. And then some very troublesome behavior began around the age of 6 years. And this was every time he would come home, it was I forget what it was, whether it was a kindergarten or preschool or whatever, but every time he would come home from his school, he would become incredibly violent and would tantrum and basically, as Mom described, tear the house apart for 1 to 2 hours until he finally exhausted himself. So that was kind of a new thing that occurred, around the age of 6 or so. Parents implemented a gluten casein-free diet on their own, and they saw some improvement in pain tolerance, but didn't really see much of a change in his aggression. We run an organic acid test, and he comes back very, very high for HPHPA, over 1,200, and an arabinose of 500. So we know he's got a Clostridia problem, most likely linked in part to a lot of his aggressive behavior, and he's got a very, very high yeast problem as well. So I attempted to do some Flagyl and diflucan at that time. Unfortunately, the die-off was so extreme, we had to discontinue. But we were able to continue with some Culturel. He was taking 1 twice daily, and a multi-strain probiotic. This was right around the time that the specific carbohydrate diet was becoming popular and well known within the biomedical world. And so it made sense to me, give it a shot. Parents implemented it, and very shortly thereafter they saw great improvements in his bowels, reduced loose stools, less bloating, less gas. He was sleeping better, and he saw a great reduction in his behavior. He just seemed happier overall. And so the outcome of that is he did extremely well with a specific carbohydrate diet, really despite the fact that I knew, at least in part, that he probably still had elevated HPHPA and high arabinose. It's just that his reaction was so severe, it was tough to go back to those medications. After 5 weeks of being on the specific carbohydrate diet, they no longer needed the naltrexone. Unfortunately, the positive effects of the SCD diet didn't last. About 3 months into the SCD diet, he became very aggressive and self-injurious again. So we performed another organic acid test from Great Plains and actually noticed that his HPHPA levels and his arabinose levels had come down to 420 and 190 respectively. But one thing that was picked up was that his oxalate levels were very high. Now, this is this topic of oxalates for a whole other presentation. But for many people, when they do the specific carbohydrate diet, it can tend to be high in oxalates, and that could be a problem for some kids. So we started looking into the low oxalate diet for him. And once they were able to successfully get that in place, it almost, completely eradicated his aggressive and self-injurious behavior. He was still a bit on edge, with respects to the Clostridia, but that was pretty well managed, with Culturelle and some, other digestive support. But the main crux of this particular case was the fact that it was the oxalate issue secondary to the specific carbohydrate diet that really drove this increase of aggressive and irritable behavior 3 months after starting the specific carbohydrate diet. So that's why it's important to be doing repeat testing, over time to check these things. Now, as a side note to his violent outbursts that would come after he came home, from schooling, and this home destruction behavior, what it turned out was that it was only occurring during the week. It didn't happen on the weekends. So it was only occurring after he came home from school. And what we figured out was that he was hungry. And as the parents went back to the school and started talking to the people at the school, he was basically skipping snacks and sometimes missing his lunch. So by the time he came home, he was incredibly hungry. But he couldn't tell anybody. He couldn't tell his mom because he didn't have any language. And he would just freak out. And so once the school made the adjustment, made sure that he ate his snack and ate his lunch, that after-school behavior went away. All right, these are a few slides I'm going to show you of what I'm calling some diminishing oxalates and fluctuating Clostridia markers. And this is just, patient D, 7-year-old autistic individual, no expressive language, poor social skills, self-stimulatory behavior, and unfortunately can become very volatile emotionally, easily upset, aggressive, hitting himself. I think you get the picture. One of the other major behavioral problems is the screaming and running through the house, many times holding his penis and pressing the groin against furniture or on the ground in an attempt, what appears to be an attempt to relieve pain. Now, digestion can fluctuate between loose and formed. There's often been, undigested food seen in the stool, and at times a sandy substance can be seen in the stool as well. Main physical finding for this particular individual has always been abdominal distension, and on lab testing, there's been these fluctuating levels of of high normal HPHPAs as well as high HPHPAs successfully treated with things like culturelle, herbs, and then very successfully behaviorally with Flagyl. So if we go back and just take a series look here, when we go back to this test in 2011, the HPHPA levels don't appear to be that high. But then they start to swing up in January of 2012. Now what I'm not showing you here is that often when those HPHP levels are high normal, he's also starting to become irritable, agitated, very moody, sometimes aggressive. And so even with that HPHPA level sitting at 156, it's normal. Knowing his behavior and knowing the pattern of what he goes through, we have initiated therapy at that point, Flagyl, and on subsequent testing, throughout the year, the levels start to dip again and he starts to do better. But he's never completely out of the woods, so to speak, from a behavioral standpoint. Now, in June 2003, the HPHP levels are starting to come up, and you'll notice also that the 4-creosol, if I go back, is generally always, very, very low. It's not been an issue. We come to October 2013, and now the Clostridia markers eventually show up very high, and this definitely corresponds, with a problem where he is very irritable, very agitated, etc. We treat with Flagyl. It tends to get better, but sometimes what happens is tests get delayed, and we notice that his HPHP levels are very high again. Now, I don't have time tonight to go into all the different scenarios of really treating for Clostridia, but the point of this is that a lot of these kids have chronic Clostridia problems that exist there for years because Clostridia exists as a spore. You can't kill the spore with the antibiotics, and there's some different ways of dealing with the Clostridia where you do cyclical doses of things like vancomycin or Flagyl, sometimes herbal remedies as well, and you get a much better success rate over time, to try to reduce the Clostridia. Let's see, why is it not moving forward? Okay. Now if we flip this over and we take the main reason I'm showing these slides is the oxalates. If we go back, notice that the test way back in 2011, his oxalates were very high at that time. And one of the things that I had recommended was really to look into the low oxalate diet. But it can be a difficult diet to do. And like anything in life, trying to implement all of these different therapies for a parent can be overwhelming and taxing. And so sometimes people are only able to implement a few things at a time just to keep, life in balance. And then, his oxalate levels continue to still be elevated. Into January, still elevated later that year. In December, they never really have gone down because they've never really been addressed. And then finally, in the summer, or spring of 2013, the parents were able to actually start learning about the low oxalate diet, have some consultations on it, and start to implement a low oxalate diet, and we can start to see that the values start to drop. Now, if we go back and we look at the previous one in December of 2002 at 223, now as of June 2013, it drops to 185, comes down to 127 in October of 2013. And then, and by the way, throughout this too, there's been a major improvement, no longer holding his penis, no longer pressing his groin against furniture on the ground, and he's just a much more happy camper. But we did a repeat test in February of 2014, and you notice that the levels are still high. But look at the reference range. What we realized on the test was that the age for this child was listed as an 85-year-old man, and so that skewed the reference ranges. When you take that number and place it into the appropriate reference range of 35 to 185, you see how where he went from 185 to 127 to 85 is a significant drop in his oxalate levels. The difficulty with him is that at the same time there's also been an increase in the Clostridia, which is tending to cloud the overall picture here. So that's why this test is important, to be able to look at these different markers and not just assume it's all Clostridia, or not just assume it's all yeast, or not just assume that it's all oxalates. Okay, so we're going to wrap up here just with a brief case on methyl B12 of a particular, and if you've seen some of my presentations before, you've probably seen this case of this particular child. This particular child I saw when they were first 9.5 years of age. They were given a diagnosis of autism at the age of 3, and at about 2.5, the parents noticed that he was appearing deaf. There was no spontaneous conversation. He had poor eye contact, poor social skills, a lot of echolalia, inattentive to the surroundings, etc. Vaccines. At one point, he had vomiting and was listless after some 7-month shots, but there was really no apparent neurological problems that followed. Medically, no major issues with his digestion, had a couple ear infections, but nothing real significant. And this was this boy, into his primary school years here. And this was him prior to his diagnosis of autism, or really prior, what I should say is before autism hit. And then this is an image of him a little older, after he'd been affected, and he's fully into the autism spectrum. And then just some images before biomedical intervention took place. Now, like many of the cases prior, Mom initiated a gluten casein-free diet back in the early 2000s, saw a slight improvement in his spontaneous verbal output, some increased conversational interactions. He seemed to be more aware of his surroundings, had some better eye contact, which is, par for the course many times with the gluten casein-free diet. We then initiated the methyl B12, and this particular boy was sort of the poster child for methyl B12 and has been for many, many years. And there's certainly been a lot of other cases over the years, but I'd like to go back to him because he was such a profound responder, and also he was older when we did it. And there's a lot of, well, I don't say a lot, but there's an attitude out in the biomedical community that if you don't start biomedical intervention at an early age, I've even heard some people say by the age of 6, it's all a lost cause. And I don't believe that to be true at all, and that's not been my experience. I still believe that no matter what age an individual is, they can be helped. And that just might be an improvement in their anxiety, an improvement in their attention and focusing, their improvement in socialization, improvement in sleep, whatever it is, but everybody can be helped at some level. So we initiated the methyl B12, huge improvements. Great eye contact, more aware of what was going on, much more engaged socially with his family, more cooperative, actually started following commands, being willing to help out around the house, just this emergence out of the shadows for this particular boy. And this was an image of him, a few years after initiating this therapy. And he was on this therapy for quite some time. I want to say probably upwards of 3 to 4 years of methyl B12. And he did extremely, extremely well. So if that's a therapy that you've looked at, I would encourage you to, pursue it. I think it tends to help a lot of kids. It's not a magic bullet. It's not the only thing it ever do. But I have found it to be very, very helpful, for many, many kids. Now, there's a couple things, if you come on late, I actually have a second edition of my methyl B12 ebook that you can get at methylb12forautism.com. And then also, some of these cases I took from my book, Autism Recovery, Autism, the Road to Recovery, which you can access at autismrecoverybook.com. And then, of course, if you came on late to this presentation, some of you probably know, but I'm always available for questions and answers through my autismactionplan.com website, where you can go into the parent forum pick a category, post a question, or there's actually a section to send me a message privately. And we've had this website in existence now for many years. And then just a follow-up is we've launched a new service for lab testing. So if you're wanting some access to lab tests and perhaps your doctor can't order it, won't order them, whatever the reason may be, you can actually get access to a lot of the biomedical and integrative medicine testing, organic acid tests, comprehensive stool, hair analysis, urine toxic metals, amino acid testing. We actually have saliva testing for adrenal hormones, sex hormones. So we're not only just servicing for individuals within the autism community, but just people seeking additional information regarding their health. And with the ordering of these tests, you'll actually get a written interpretation from myself or my partner, along with at what we call action steps that can be taken, whether those supplement recommendations or medication recommendations, protocols, etc., based on those lab tests. So that information can all be accessed at labtestplus.com. And then if you just want to get additional information about myself, go to drwoeller.com, and there's links to my office website. There's links to the various books and other websites that I have online. And then, of course, I'm always available for private consultations, whether it's in person, phone, do a lot of internet consulting, particularly with people outside the U.S., but certainly within the U.S. as well, doing health consulting. And again, drwoeller.com is a place to access all of that information. So with that, everybody, I hope you found this information useful. I will do some further presentations in the future regarding various case scenarios. There's just so many things to talk about, but I wanted to be able to hit on a few of them tonight from information I've presented before, but the stuff that comes up so much, because the dietary things and the yeast and the bacteria stuff just comes up so much for kids. I want people to be really aware of that, because there's a lot of people that sometimes inadvertently pass over it and don't see the results with their child, and it could just be a major roadblock to their further progress going down the road here to getting help for their issues. So with that, I hope you have a good evening, and we will see you next month. Thanks so much. Take care.